Okay. So for those of you who haven't met before, I'm Jill Swallow. I'm one of the haematology consultants based in Nottingham and part of the BSH Zambia Task Force team who are lucky enough to come and visit you all in September. I want to introduce Dr. Judith Moor, who's slightly different approach today. We've got a consultant obstetrician talking as opposed to our usual haematology team. We thought it would be interesting to talk about PPH from more of an obstetric perspective with some added haematology thrown in there as well. So thanks very much, Dr. Moore, and I'll let you get going.
So, Orton, I don't know whether anyone has prepared. I thought it might be interesting to have a case of postpartum hemorrhage from you, just to see whether you have the same approach as we have in the UK. I don't know whether have you been able to do that.
Yes, I managed to prepare something, although the presentation, I'm not quite done with the final touches, so I'll just present without the
Okay,
presentation.
okay. I said my curiosity, as much as anything, was to compare thoughts on how you approach postpartum hemorrhage. I suspect that we're very similar, but it would just be interesting for me. So if you'd like to go ahead and do that. What I have got are four cases of completely atypical postpartum hemorrhage. I haven't presented them in any great detail. They're quite anecdotal, but it was just to discuss that, and any input from Jill would be really welcome. So do you want to start with your presentation?
Yes, I can start with the presentation. So we had a patient, she was 50 years old, a prime gravida who came to us at 37 weeks with a pregnancy that was conceived through assisted reproductive IVF. So she came with, she was referred from the local clinic because she had a thrombocytopenia of 86,000. Otherwise, everything else was okay. And this is a patient who had a mammectomy that was done previously. So she's a patient who was initially when she came through, the hemoglobin levels were within normal. It was around 11. Then the platelet count, like I had mentioned, was 86,000. So the concern was that due to the low platelets, we were supposed to plan a delivery. So we had planned to deliver her on the the 1st of December. So it's a recent case. Patient was just discharged today. So we had planned to deliver via cesarean section on Monday, which was the 1st of December. The time that we were reviewing her, unfortunately, she had gone into some form of respiratory distress because of the pressure symptoms. So she was having difficulties breathing, especially when she lies down because of the overdistension of the uterus because of the twin pregnancy. So she ended up having an emergency cesarean section, of which at the time of the cesarean section, she had a blood loss of 2,500 mils. So what was noted during the operation was that the blood loss was significant because of the difficulties to achieve contraction of the uterus, but we managed to preserve the uterus in terms of we didn't remove it, so the uterus was preserved with a B-linge and uterotonics. Then during the procedure, she also received some blood transfusion. Most of the blood was red cell concentrates and fresh frozen plasma. And this is a patient that also had tranexamic acid 1 gram and misoprostol, which was used as an additional uterotonic. Then she had a drain that was left just for concerns that maybe she might continue bleeding. But day 1, day 2, up to day 3 post surgery, there was no notable bleeding that was coming from the drain. So it was removed on day 3 post surgery. This is a patient that did well after surgery. We collected the full blood count post-op. The hemoglobin levels were 9.5, which is about 95 if you're using milligrams per deciliter. Then the platelet count post-delivery was 110,000. So we managed to discharge this morning when we we're doing a major ward round. So the important things of note is usually when we have cases of PPH, the major challenges that we have is in terms of doing the clotting profile. So if we are doing a goal-oriented management, we are supposed to have levels of fibrin in terms of how to assess the severity of PPH if it's ongoing and how we need to correct those levels. But in our setting, we rarely have or we're rarely able to do the clotting profile. So most of the times it's acting presumptively. So if, in cases where we have fears of DIC, it's mostly just giving the blood transfusions, and we rarely have fibrin as an alternative to give in our patients. Although we use, in terms of the major hemorrhage packs, we use an adaptation that was made, I think it should be the UK guidelines, where we have a major hemorrhage pack. Pack one has 6 red cell concentrates and six, sorry, pack one has 4 red cell concentrates and 4 fresh frozen plasma. Then pack 2 has 4 red cell concentrates, 4 fresh frozen plasma, and 6 platelets. Then in pack 3, there is an addition to pack 2 of 2 cryoprecipitates, which I think was adopted from some of the guidelines that were in the UK. So when we have a case of major hemorrhage like we had, we usually activate, there's a group that we use on WhatsApp where we will activate a pack that we need. So in this case, if we activate say pack 2, means that someone will make a follow-up to blood bank and will be given whatever they have at that particular time. So if they have the 4 RCCs and 4 FFPs with 6 platelets, they'll give us. But sometimes because of the challenges of blood availability, because in Zambia we don't have a system where we pay for donations, usually it's voluntary donations. So sometimes you would request for a pack 1, but they can only give you maybe 2 RCCs. And at that point, maybe they have 1 fresh frozen plasma. So they'll give you whatever they have at that particular point. But for women and newborn where I work, the advantage is that we have a blood bank in proximity. So whatever we request, usually we get some form of, we get support actually because it's nearby. Sometimes you would get not necessarily the support that you had requested, but still would get most of the blood products that we needed. Yes, I think I hope I've painted a picture of what we
Yeah,
we
I mean, it is remarkably similar to how we would do that. I didn't really expect there would be any great differences, but I thought it would be nice to hear a little bit of your experience because the 4 cases I'm going to present are far from typical, and you'll understand why when I start doing them. And in fact, they're the sort of cases where it's always quite nice if somebody's encountered this before and you can call on their experience. Although when I encountered each of these, I hadn't had experience of this before. But they're quite nice because they're unusual. So what I'm going to do is I'm going to share
Judith, can
my
I ask a question first? Is
yeah.
that all right? Autumn, can I just ask a question? So I think one of the things that was springing to mind when you were describing that case was, this was a twin pregnancy. She had a thrombocytopenia. I'm presuming it's quite rare that you will have a baseline for blood count for somebody. Is that correct? I.e., they've got a non-pregnant blood count been done.
Hi.
So most of the times, in terms of antenatal reviews at booking, the recommendations, the guidelines that we have in Zambia is that booking, we do a full blood count. For those that are in rural outskirts, there was use of a hemoc, which just tests the hemoglobin. But for the others, we use a full panel of the full blood count. Then we'll follow them up with full blood counts depending on the people that are reviewing them. If there's a need, sometimes they do maybe 3, 4 full blood counts as we are monitoring them. So this is a patient that had been noted to have a thrombocytopenia even before pregnancy, but it wasn't in the severe ranges.
Yeah.
Yes. Then for follow-up, she had what looked like had been worsened by the gestational thrombocytopenia because it never went significantly below 100 and it never reached 50,000.
Yeah, no, that's sort of what I was asking really, I guess, because and most of these thrombocytopenias in the third trimester, in an otherwise well woman who's not got preeclampsia or anything obstetrically will be gestational. But there are always going to be cases out there of women who have thrombocytopenia, inherited conditions, or some of the rarer bleeding things. And I think we talked a bit when we were presenting when I was in Lusaka about taking bleeding histories, because actually a simple bleeding history if somebody's been through operations before, dental extractions before, that kind of thing, and not bled can be quite helpful to determine whether this is just somebody who has a gestational thrombocytopenia, or whether somebody who actually might have an underlying platelet problem. But the bleeding that she had, do you think it was typical for the clinical situation? You said she had an atonic uterus and the blood loss. Do you think that the bleeding was consistent with the obstetric situation that you were in?
Yes, so the concern for her was the twin pregnancy. So there's over distension of the uterus. So there
Sure.
was an anticipation during the time of delivery that she might have more bleeding than usual.
Thanks, Autumn. Thanks for that presentation. Sorry, Judith, I interrupted. I'll let you continue.
Okay, that's fine. So I've got a presentation here, which hopefully is going to share. I need to put it onto full screen. Just give me a minute. Can you confirm that you've now got a blank screen on there?
Yeah, we can see that,
Yeah,
Judith.
okay. So the principles of managing PPH, and I'm not educating you here. I'm just this is a starting pointer of tone, trauma, tissue, and thrombus. And certainly in the UK, we always think of it that way. And when we make an evaluation of somebody, we look to see if there's atony, we look to see if there is traumatic bleeding, we look to see if there's retained tissue, and we think about the coagulation aspects. So these are cases that I have encountered over my career, and there really are sort of once in a career sort of cases because of the way that they turned out. I thought might be interesting to look at in the context of obstetric bleeding. So the first case, I was still in training at this time. I was on the senior tier of training and I was on call from home. And I got a call maybe about 2 o'clock in the morning from my registrar to say that this woman had been admitted. I think she'd had a minor bleed. I can't quite remember. She'd been completely normal up to this time. She'd had midwife-led care, so she'd had no input from the obstetric team up till this point. Everything completely normal. And I think there was a CTG change and she needed delivery and she needed it quite quickly. I'm a bit hazy about that, but we decided she was going to have a cesarean section. We were going to have a cesarean section. Sorry, Jill, this might be my car. Can I just take this call a second? Oh, it's gone. It's gone. And the only other thing was she had a minor degree of hypertension, something like 135/90, nothing that rang alarm bells, but this was new in her. So she went ahead. I went back to sleep because I was at home, and that was it for several hours. Probably about 4 or 5 hours later, the registrar rang me back. They'd noticed some changes, probably a change in her early warning score, a bit of a tachycardia. She dropped her hemoglobin and she says she's bleeding. I'm taking her back to theatre. And I actually don't know what it was, but I said, no, you don't take her back to theatre. You wait till I get in there and assess her. And there was something that told me that I needed to see this. And so it took me less than 15 minutes to get in. I saw her and I scanned her abdomen. She was a nice thin woman. I scanned her abdomen. There was no blood in her abdomen. There was no blood vaginally, or not anything out of the ordinary to what you would expect after a cesarean section. And I said, I don't think that she is bleeding. I think that we might have HELLP. I look back on that case now and I can't quite remember what made me, sorry. Hello? Yes. Is there any chance that I could call you back in a bit of time? I'm teaching at the moment. I'm in the middle of a session. Yeah. Okay. Okay. Cheers. Thanks. Bye. I have a non-functioning car, and it's really quite important for me to get it sorted out. So sorry about that. Um, so uh, I don't know what triggered all my concerns about this, but it turned out that I was right. And she continued to be really quite ill, but it took us quite some time to convince people that we had HELLP syndrome. Over the course of the next 24 hours, she had a very stormy time. The first thing that we noticed was that her urine was Coca-Cola coloured. And of course, with HELLP syndrome, you've got hemolysis, so you're not going to find hematuria. And the urine testing sticks, people check for blood, and they didn't find anything. And it was no, we have to look for hemoglobin urea. We need to test for that because we're not going to find that. And when we got the right dipsticks to test for that, because we don't normally need to test for that, we confirmed that she had quite marked hemoglobin urea. And she dropped her platelets down to about 30, I think, over the course of her illness. She had changes in her liver enzymes. We sent off a blood film urgently. This is still in the middle of the night. To look for red cell fragments, and we were told quite clearly by the person in the laboratory that no, this is not hemolysis. There aren't many fragments there. There's only a couple, and we were saying no, this definitely is hemolysis. We've got everything else uh, um, pointing in that direction, and so by about 9, 10 o'clock in the morning, we had absolutely everybody in there, the consultant anaesthetist, the consultant obstetrician, all the different levels of anaesthetics and obstetrics. But this woman just kept getting worse and worse and worse. And we supported her over the course of the day, but she ended up with pulmonary edema because of the degree of hemolysis that she had. And she went for hemoglobin, and she went for paracentesis, electrophoresis, because she couldn't clear, her kidneys were so clogged up, she couldn't clear anything. And she became very, very unwell with this. One of the tests, which we don't have available to us in obstetrics in our department in Nottingham, but we did have in Leeds, where I was working at the time, is the thromboelastogram. And they did a thromboelastogram on her. And I don't know whether this is something that you have any awareness of, but it measures the strength of a clot. And they compare them to wine glasses. So somebody who clots very easy has a big fat red wine glass, and somebody who doesn't clot quite so easily has a champagne glass with a much narrower flute. She had a flat line. She was so compromised. She actually did very well. And she spent quite a few days in as an inpatient, but she went home and she was completely healthy. In my career, I think this is the worst case of HELLP. I don't think anything I've encountered has ever come quite so close to this. And one of my colleagues went to see her when she was still in the critical care unit afterwards, and said, if Judith had taken you back to theatre when everyone thought you were bleeding, I don't think you would have survived this. Now, I'm not absolutely sure that's true, but it is something that's made me think. And how important it is to try and establish, not to go with what seems to be the obvious thing. She's dropped her hemoglobin, she's got a tachycardia, she must be bleeding. This woman wasn't bleeding. Well, she wasn't bleeding until she couldn't clot, but that wasn't the reason why all these changes had happened. The reason these changes had happened was because she was fundamentally hemolyzing, but all the other effects of HELLP as well. And fortunately, I've never had to deal with anyone quite so ill since, but she did do her best to make it challenging for us. And you know how some patients, you remember their names. I remember the first patient I ever saw when I was first doctor. I remember the name of them and I remember what they looked like. She's another of those patients that I remember very clearly because she was so critically unwell. And it was quite a learning experience for me. So the second, just to summarise, she hemolyzed, she had thrombocytopenia, she had hemoglobinuria, she had liver dysfunction, she had renal dysfunction, she had pulmonary edema and temporary hemodialysis to sort out her fluid overload. So the next two cases are quite similar but opposite. So the second case was a woman who had come to the UK having had a myomectomy in another country. Myomectomy is not uncommon in the UK, but I don't think it's as common as it would be in your practice. And we usually do myomectomies for women who have fertility problems. One of the debates we're having in the Royal College of Obstetricians and Gynecologists now is whether we should include myomectomy within our syllabus for gynae operating as a requirement, because it is very dependent on what part of the UK you're in, whether myomectomies are done or not. So in places like Nottingham, we have a very, very diverse population, both of people who are British, born of different heritages, but also of people who have immigrated into the UK. So we do quite a lot of myomectomies, but in parts of the country where there is a substantially white population, it's much less common to do it. So it's an interesting debate about whether there is enough exposure to myomectomy to make it a requirement for gynae operating to develop your skills. But anyway, back to this woman. This was her first pregnancy. And she had an elective cesarean section. She had an elective cesarean section because we didn't really have any details about what had happened with the myomectomy, and it was the safest thing to do. And I happened to be doing elective cesarean sections this day, and she had a lovely, straightforward cesarean section, lovely birth, nice happy baby, nice happy mum, until we delivered the placenta. And at the point of delivering the placenta came away, but didn't come away completely. And there was, in my mind's eye, as I remember it, a strip of placenta remaining on the decidua, which probably represented where she'd had the myomectomy scar. So, okay, what do we do about that? Well, she's not bleeding. We can't get this off. We'll probably make her bleed more if we take it off. And when I say there's a strip of placenta, I'm not meaning full thickness. I'm meaning a residue of placenta down there. So she'll be fine. She's not bleeding. It will sort itself out. The sort of problems that we can anticipate from this is, well, she's got potentially dead tissue there from the placenta, so she might get infection, or she might have a secondary postpartum hemorrhage. In fact, she did very well. She had no problems whatsoever, but we talked through what she might expect, when she might expect it, the unpredictability of that, and she did very well. She did very, very well. We had no issues with her whatsoever. But I'd like to contrast her with my third case. And this is a woman who had an IVF twin pregnancy. In the light of this case and discussions with this, I discovered that IVF is a risk factor for placenta accreta. There are more cases of placenta accreta in women who have had this sort of assisted conception, probably because when the embryos are transferred, the catheter transferring the embryos penetrates the endometrium, and so you get abnormal initial placentation, which then goes on to be a morbidly adherent placenta. So just bearing that in mind as we go through the rest of the case. She also decided that she would have a planned cesarean section. She also had a lovely cesarean section, birth of two beautiful babies, everybody happy until we came to deliver the placenta. And on this occasion, exactly the opposite happened. The placenta took away a strip of a patch, I would say, of decidua. And having revisited this case recently, I know that it was probably about 2 to 3 centimeters by about 2 to 3 centimeters. And the base of this patch where the decidua had been removed with the placenta was bleeding, but not bleeding very much. It was too wide to think about over sewing it. That was probably going to cause more bleeding in the long run than not sewing it. But we had to do something to make sure that this bleeding stopped in its own natural way as we expected it to do. So what we did was we put in a Bakri balloon. Now I'm assuming that you have some familiarity with a Bakri balloon. I've got a picture of one in a minute, but basically if you don't use Bakri balloons or you use something that has a different name, it's a balloon that's put into the cavity of the uterus and you inflate it with water, and it provides internal tamponade. Under direct vision, because we had sewn up the uterus and we hadn't sewn up the abdomen so we could see what was happening, we put 500 mils of water into this Bakri balloon. Now, usually with a Bakri balloon, we put in probably 300, at most 400. So 500 mils was an awful lot, but we could watch the uterine incision and make sure that it was still healthy at the end of it and we weren't causing undue strain. And we put in as much pressure as we possibly could. When we'd finished the procedure, we put in a vaginal pack to help retain the Bakri balloon. Okay, so she then went back to labour suite to observe because we were worried about her. We knew that the solution to the bleeding was to give it time to sort itself out by putting pressure on. So there was a risk that wasn't going to work. And she actually seemed to do well. There was minimal vaginal blood loss. There was nothing draining through the centre of the Bakri, and I've got a picture of that to show you what I mean in a minute. But she says, I'm uncomfortable, and she was getting some cramping pains, so it's after pains. And then I'm uncomfortable, and she got more and more uncomfortable very, very rapidly. And I was in there, and my consultant anaesthetic colleague was in there as well. We were trying very hard to work out what was happening. Vaginal inspection, there was no obvious blood loss. It was absolutely fine. There was nothing draining from the Bakri, and her abdomen was soft, and there was nothing to suggest that she had intra-abdominal bleeding, which of course was another possibility, particularly as we had all this fluid in the Bakri and whether it was putting strain on the cesarean section scar, all the different things that we thought about. But she was getting more and more and more distressed, but we couldn't find any blood loss. And then we did a few things to try and sort out what was happening. We took some fluid out of the Bakri balloon because we thought maybe it's so much fluid in the Bakri that the uterus is contracting against it, so she's getting profound after pains for that. It didn't seem likely, but we thought we ought to try it, so we took a bit of fluid out. It didn't make any difference. The other thing is that when we're trying to measure urine output in somebody where it's important to be accurate, we don't use a catheter bag, we use a uretainer, which is the solid plastic urine collections, which drain much more easily than the soft bags. And so I thought, okay, it's a soft bag on here. Maybe she'll drain a little bit more if we put the uretainer on. So we took the soft bag off the end of the Bakri cannula, and I am going to show you this in a minute. And we put the uretainer in. But whilst we were doing out came this very, very long, thin clot that had filled the Bakri balloon. So here's the diagram I've been promising you. So this is just a schematic that I did to try and demonstrate. You've got the Bakri balloon. Do I have a? Yes, I do have a pointer. So you've got the Bakri balloon that you fill with water here, and it's a donut-shaped balloon with this central cannula, so that central lumen, so that if you have got any bleeding, the bleeding comes out and you can see that there's bleeding there. This is just to represent that there's a separate channel to that. They actually run alongside each other, but there's a separate channel to that that you put the fluid in through. So we had been expecting, if there was bleeding, that we would see it. But in fact, what had happened, she was bleeding frank blood and it had just clotted. So an important lesson for me from that is using a Bakri balloon has its downside, because what you do is you just basically block off the outlet from the uterus, and you don't see anything because it clots if you've got proper bleeding. And certainly when we discussed this afterwards, none of us had thought of that before. So it was an important learning point for us. And what was actually happening was that we basically plugged the cervix with the Bakri balloon, and she was still bleeding, and the blood had accumulated behind the Bakri balloon, and that's why she was in so much pain. So anyway, we took her to back to theatre, removed the Bakri balloon, and lots of blood came out. The total over the entire procedure was 8.1 litres, so huge blood loss. And we did a hysterectomy to resolve the bleeding, because there had been no point in trying. It would have been a futile exercise to try and sew the denuded area at the time of surgery. So there's definitely no reason for messing around with doing that afterwards, and she had a hysterectomy. She actually did really quite well from an obstetric point of view. She recovered very well from this. Psychologically, she was deeply traumatized, and still really has not recovered completely psychologically from what happened to her, because she remembers just how frightening it was when she was in so much pain. And much as we were trying really hard to work out what was going on, and it didn't take us that long to work out what was going on, she sees that as nobody listening to her, and it taking a long time when she was left in pain. So it's somewhat marred the birth of her babies, and certainly has overwhelmed her experience of that birth. So then my final case, again, something slightly different. This is something that is reasonably unusual for us, but you might have more experience of this because of the greater incidence of fibroids in your population. But this is a woman who I suspect both Jill and I knew, but I knew her from pregnancy, and that was because she had a DVT in pregnancy and she'd been taking therapeutic enoxaparin. That's actually reasonably irrelevant to the rest of the case, but that's how I had got to know her, and I think Jill had got to know her too. She was known to have a fibroid uterus, nothing particularly amazing. It wasn't a big fibroid, but it did impinge into the cavity of the uterus. She had a nice normal vaginal birth, straightforward third stage, and a slightly higher blood loss at 1.2 litres. Due to atony, but the atony was reasonably easy to correct, and she did very well. However, when she got to 15 days postnatal, she was brought back in as an emergency. She had a secondary PPH, and quite a significant PPH, with an estimated blood loss of 2 litres and a hemoglobin dropping to 68. The consultant obstetrician who was on call that day took her to theatre and did an evacuation. She used a suction catheter and evacuated the uterus, and it says that tissue was sent for histology, but there isn't anything ever retrieved from that. My experience of these is often it isn't tissue, and there wasn't any definite tissue identified. Nothing that clearly looked like placenta. But often this tissue turns out to be just fragments of decidua and blood clot, but we won't know that. My feeling is that there probably wasn't much in the way of tissue, retained tissue, rather than the resolution and breakdown of decidua and blood clot following a straightforward normal birth. She was treated with uterotonics. She had a battery balloon put in and went home, not with the battery balloon in, after it had been removed. But she was readmitted another 7 days later, so she's now 22 days postnatal, and she had another significant bleed. Now, I happen to be on call, so this is my personal contact with her in the intrapartum stage of her birth. She reported significant bleeding, and that's really all we had because it was what she was reporting. But her hemoglobin was 78, and considering she'd been transfused last time, this was definitely a drop. The scans suggested retained tissue, and scans aren't all that helpful in looking for retained tissue because it's hard for them to differentiate between tissue and clot, but there was certainly something within the cavity of the uterus. We debated what to do about this, and there was certainly one school of thought that it was an experienced surgeon, so there won't be retained tissue there. But she continued to bleed, and so she went back to theatre, and we did a further evacuation, but this time we did it under ultrasound guidance. And here is another of my schematics. This is sort of to give you some representation of what her uterus looked like. So she had this fibroid impinging into the cavity of the uterus. So this is nothing like a suction catheter, but it was the best I could do with the package that I had. Watching this, and I was scanning, and another consultant colleague was doing the evacuation procedure. While we were watching, my colleague put it in. She's right, I've reached the fundus. And I could see, because I was doing the ultrasound at the time, and said, no, you haven't reached the fundus, you've reached the fibroid. So watching this all the way through, because we were conscious that there was a risk of perforation, we manoeuvred the catheter around the other side of the fibroid. And in this area here, there was some dense black blood retrieved that hadn't been found the first time. And we think that probably what happened when they did the first instrumentation of the uterus, they only reached this fibroid and thought that they'd reached the fundus. So all this black blood came out. We completely emptied the uterus. I was just a little bit concerned that I could still see some blood reaccumulating. And a little bit of anxiety that wasn't just because we disturbed the myometrium when we'd done the evacuation. I went to see the woman afterwards, and she was deeply upset at the fact that this had happened twice. And she said, "Now, will you guarantee to me this isn't going to happen again?" And I said, well, I can't absolutely. We have assumed that this was down to some retained tissue to a degree of atony. But there are other reasons why you might be bleeding, and on what I have at the moment, I can't eliminate those. But certainly, what we need to do is, if you come back with another bleed, is to look for some vascular malformation that might cause bleeding. We at the time we carefully examined all the matter that we removed, and we were able to establish that it was only blood clot. There wasn't any tissue in there. She was readmitted again at 54 days postnatal. And this time she had interventional radiology with an angiography that confirmed an AV malformation, and she had this embolized and cured. So these were 3 significant but isolated bleeds. She did not have any unusual degree of bleeding between these bleeds, but she had 3 episodes of quite major secondary postpartum hemorrhage, and it ultimately came from an AV malformation. I don't know how much the fibroid contributed to that, but the fibroid probably clouded the first evacuation, and made it took a little bit longer to establish what the cause was. Also, the fact that we didn't have histology. I think if we'd known from the histology of the first procedure that there was no tissue in it, there was no retained tissue, then it might have prompted us to work out that there was definitely another cause behind this at a sooner stage. So that's going through my my 4 cases with you, which I'm trying to get back onto my meeting now. Here we go. Going through my 4 cases with you. I thought they were interesting. They challenged me. As we often say, it's not good to be interesting around doctors. All these cases were very interesting, and I learned a lot from them. And I thought it would be useful to share these for you and maybe open up a little bit of discussion about what you think. So these sort of stories, when you hear other colleagues telling you about their experiences, you sort of put them in the back of your mind and think, oh, I hope I never have to call on that, but now I've heard that, I will be able to if I need to. So none of them really fit into our typical tone, tissue, trauma, and thrombus, but they all have components of that. And certainly it was part of the differential diagnosis and assessment as we were assessing all these women. So I've said my bit. Have you anything you would like to discuss? Anything from you, Jill, that you'd like to put in as thoughts from those?
No, no, not at all. Just that I'm very grateful that I'm the haematologist on the end of the phone and not in the operating theatre with these women when they're bleeding.
Yeah.
So any questions from the team from Lusaka or from Zambia? Any questions, any queries, any comments or similar cases that you've managed yourselves?
Sorry, I wanted to ask on the case that you had presented where the blood loss was 8,100.
Yeah.
In terms of, I'm assuming that for that patient, she had a massive blood transfusion. In terms
Oh,
of
yes, yes.
mitigating the effect of GIC after giving that massive transfusion and fluid overload,
Oh
how
yeah,
did
yeah, and I haven't really gone into that. This was a team effort, and one of the nice things that comes from the way that we cover our delivery suites here is you work with an anaesthetist who you know and trust. And we were very, very much in this together and making decisions together and helping each other. So when we got to theatre, Mel just got on and sorted that side out and trusted me to get on and sort the bleeding out. So yes, she had extensive transfusion of both blood and blood products to keep her alive. I remember saying to the woman afterwards, because she said she was on about, I thought I was going to die and all this thing. And well, I never thought you were going to die. I knew what the cause was and what we had to do about this. Whereas Mel, the anaesthetist, said when she saw all the blood on the table when we took the battery balloon out in theatre, she said, I thought she was going to die. So it really was quite a major quite a major hemorrhage, and it happened quite rapidly. From her first getting symptoms, being back into the theatre was about 30 minutes, and that was all working out what was going on and trying to solve and plan for what we needed to do to keep her safe. It's all really nice and obvious to me now when I look back on it, but in real time, when you were trying to understand, it just didn't make any logical sense. Any other comments or similar circumstances?
Yeah, that's me. Okay, so as ever, please do feel free to email any questions or comments via Orton back to us. Also, these sessions will continue in 2026, and we're really keen to discuss interesting cases that you've had, interesting topics. So if you have had cases or suggestions for topics, and please again do let me know. Orton, I'm more than happy for you to share my email address with your team just so that you can keep in touch about what sort of topics you want to cover. And yeah, that's all I was